care is a last resort, really, when it comes to health. We know from a big body of evidence that the determinants of health really are social and economic and biologic in ways that are about populations, not about individual patients. So if we want to improve health of the people in our service area, we have to do something that is not about clinical care and direct care to individuals. We have to go upstream from that. So that's the first part, and as a clinician I feel like that's in my bones, because the people who walk into my exam room are still on their feet, but they are suffering from, in many cases, from things that could have been prevented in a different strategy. So that's about improving health. So your question is, why am I comfortable with, or was I interested in, our pursuing social policy influence and advocacy in community engagement? And that's the only way that you can do population health. These are social policy issues. We know that educational attainment and zip code and other determinants like that are really what's behind people's health status. So you get at those things with social policy. And in turn, social policy is driven by communities. You don't need just buy-in from community members, you need leadership from communities, or else it all goes away. So community engagement becomes completely intrinsic to influencing social policy. So bringing it all back together, we're not going to improve health without looking at those sorts of determinants, what happens in society, and we're not going to get at what happens in society without supporting communities and helping with leadership in communities. We get to steer our own ship, and our mission has been clear what we're about. So we have this great privilege. We have limited funds, but we can leverage and use them in ways that are creative and innovative and sometimes experimental. So why social policy and why community engagement? For the reasons I said before, this is where we can maximize our limited funds, where they'll have the most reach, where you get the most return on investment, which does matter to us. So we'll affect many, many more people's health, we think, from well-chosen social policy work and initiatives and community empowerment and engagement initiatives than even our very best grants to direct service delivery. We arrived at where we are, which I think is still early in our journey on this, but we arrived where we are with a lot of intentionality, and we snuck up on it in some respects. At the same time as we were having our first discussions about going in this direction, we were also educating ourselves about what we legally can do. And because of our particular foundation structure, we have options for advocacy and education. We have options for lobbying, and now we make full use of all of that. But we were having, too, these internal debates and self-examination, self-education about where we could do the most with the funds we have. So I think the moral of the story is it was intentional, it was quite systematic, and where we've come is that we have adopted, created and adopted certain analytical tools that help us keep the compass pointing in the right direction. For example, we have tools of analysis when we think of a prospective legislative action or a legislatively related action that tell us to ourselves the risks to the foundation, the risks to others, and the benefits, so that we really try to map those out and articulate them. I think that's a very good kind of thing to do. We also have developed systems to guide us where there are areas with very well-described parameters where the staff or certain board committees or even consultants can act nimbly, can act quickly on our behalf when there's a lot of dynamic change and there are timelines attached, while still staying on course that for the most part we need to examine this very carefully, all prospects of really public action and advocacy, with lots of research, full board and full staff involvement, and then decision-making that's quite transparent. So those are our systems. We have something that's a little more nimble, but even there, it's very carefully mapped out, I think. And for the most part, we look to systemic, select, very judiciously chosen actions. I really have two pieces of advice, I think, principally. One is, let's use our financial strength, let's use our funds to incentivize new kinds of collaborations, new partnerships, bringing people together who haven't been together before, and helping to set policy or build community. That's a really great thing we can do, and that works. And we've had that convening role in our foundation very successfully, I think, and we're learning more about it all the time. The second thing I think I'd say to other funders and grant makers in health is, it might sound a little strange, but I would suggest that we all think of clinical care as disaster relief in America, just as if we were going in a flood when the levees break. You know, there's a lot of compassionate need to go in when the levees break and do all you can to help people, individuals and groups. It has to be done, but the levees are going to break again in the future if you don't do something to prevent that. You invest in the infrastructure, and you do preventive strategic planning and long-term planning, and you envision what's going to come and what has to be done to prevent the worst the next time. That's where the real investment pays off. And I think it's not too much of a stretch to say that American healthcare is in large measure disaster relief, given the disparities we have now. There are a lot of bells and whistles that can look pretty fancy in America, but all you have to do is look at our health outcomes to know we're not reaching the place we want to reach with all of the best medical care we got.